Welcome to this special live edition of the eClinicalWorks podcast at the 2022 eClinicalWorks and Hilo National Conference. I'm Adam Siladi, and thanks for joining us. As value-based care brings changes to traditional office processes and provider responsibilities, it can be easy to view value-based care as adding to physician burnout. But could value-based strategies actually offer solutions for overworked providers who, when implemented correctly? And here to discuss these ideas with me and how they can be put into practice is Dr. Dhrumil Shah, CMIO and physician at Compass Medical, a 150 provider multispecialty group in East Bridgewater, Massachusetts. Dr. Shah, thanks so much for joining us today.
Thank you for having me.
So let's get right into this and ask you, what are your thoughts on the relationship between value-based care and physician burnout? How are those related?
I think the value-based medicine, as we all know, is shifting the way we pay for healthcare. And when we look at the physician burnout, a lot of research has been done over the last 10 years plus, where the physician burnout is a manifestation of moral distress and moral injury. A lot of it happens because of systematic changes, what we have implemented, which has added to physician burnout. So most of the experts will say value-based medicine is adding to the stress, but there is a silver lining where when you change the way you pay for healthcare, you practice healthcare differently. And I think I am more of an optimistic individual who believes the value-based medicine truly changes the way you have to practice medicine. And the best example is taking care of an adult primary care requires 26.7 hours in a day. A recent article was published in July. That is just not possible by any one individual doctor. So you have to implement team-based care for what is needed today. And we did a lot of the work in the past. It's just a different type of work.
Now, also in that study, I think you mentioned that they did say that an individual provider might have to do 26 hours of work in a day, but that there is a way to get that down. There is a way to reduce that. What else did that article say about that concept? How do you get that down?
Yeah, I think the article which I'm referring to is recently published in July from Journal of General Internal Medicine, where they revisited the idea of how many hours you need to do the adult primary care work. It was 26.7 hours. When you do the same work in a team-based environment, you can bring it down to 9.3 just by having a team-based environment, which is nothing but a redistribution of the task and allowing your team member to work at the top of their license and at the top of their training. When you implement those models and build the care teams, that changes the way physician burnout is perceived. And I think we have seen the experience myself in my practice and other providers within my practice. There are variations on how you do it, but that's the gist of what that article is meant to do. Is that 9.3 is still not ideal, right? Let's face it, the 9.3 is still, you add 7 hours of sleep, you're not spending time with your life and family. So 9.3 is not an ideal state, but that should be a starting point at least.
Right. Now, what about the differences that you see between the fee-for-service expectations and the value-based care approach? How are those tasks different?
I think the biggest difference in fee-for-service and value-based medicine is in fee-for-service, you are responsible for what's in front of you. Versus value-based medicine, it makes the black box completely your responsibility. The black box being what happens to patient between encounters. So as great as it sounds that our growth, eCW has 350 plus million encounters, all those encounters are still a point in time in patient's journey. And 99% of the time, patient spends outside of the healthcare buildings. So that 99% is a black box for us. And value-based medicine makes you think differently about how you take care of those patients. So the fee-for-service is all about what's in front of you. Value-based medicine is what you're actually not aware of, plus what's in front of you. That's why everyone sees it as a more work and physician burnout. But when you take and spin it on its head, you actually start to think this is the right medicine. You want to keep patients out of the hospital, out of the sickness. We don't want patients getting diabetic complications and amputation. We want to manage the A1C. And not alone that, we want to also manage their conditions at home.
Yeah, healthcare versus sick care is, I think a lot of people describe that. So with that in mind, right, with the understanding that team-based care is as you said, the first step that you need to take to get that provider responsibility and provider time down. What is Compass Medical doing to implement team-based care, and what tasks have been redistributed?
I think the biggest example I can share with you is, first of all, taking a step back, it needs to start at the culture. Everyone has to use the language of team care. They are not employees. Your team members are what's helping you, right? You are no longer a individual contributor of patient care. As a physician providing care, you are one of the clinical care team member. The tasks what we have redistributed are the ones which are repetitive, doesn't require a physician or a provider license. And the best example I can give you is we implemented low-dose lung cancer CT scan screening program back in 2017. And we are one of the Center of Excellence in Massachusetts. We have done 67% of our eligible population already received the screening. But we did that with the team. The physician have to do bare minimum. What I mean by that is all the questionnaires, all the requirement for the screening, they're all one-click templates. And all physician has to do is once patient has been identified by the clinical staff and eligible, and patient has shared the interest, they are willing to participate in that, they have to use 3-click order set just to get to what they need to do for that patient. So that concept of one-click templates and 3-click order set has been very successful for us. They are simple tools. eCW has them for many years. It's just how you use them and who does those tasks.
Yeah, that's a great way to reduce variations in care as well. And as you've just said, make sure that your other teams are able to take part in that. What has been the response from your teams in terms of giving them some more of that responsibility? How have they reacted to that?
At first, the physicians had hesitations, but when they saw the joy in their clinical team members, because if you imagine, the nurses did not go to nursing school just to take vitals and walk away from the exam room, right? The nurses know the healthcare much better than physicians. That's just my biased opinion, because we see a spectrum of the healthcare at the episodic care. The nurses have the most compassionate training experience of being with the patient in various domains. So all those clinical staff members, whether it's a nurse or a medical assistant, they actually felt they contribute to the care of the patient rather than just doing a task, entering a data, making the click, and everything else you have to ask doctor for the answers.
It sounds like it makes it more meaningful for those other team members to take part in the patient's care. So let's talk about automation a little bit. Where are you taking advantage of automation to even help those other team members? And I guess specifically, are you importing questionnaires into your visits, from the patient portal to make sure that your staff doesn't have to manually enter information during the visit?
To answer your question, I think we do some of it, not all of it, but I think we are actively working on Hilo check-in and portal questionnaires import. But what we started with something which is basic, which we already have the structure in place, PHQ-9 for annual wellness visit. Then you do a depression screening at annual physical or fall risk screening. All of those screenings are done by clinical staff with prompts which are generated by the eCW templates. And when the provider goes in, they're actually addressing the abnormal screening rather than actually performing the screening. So the redistribution of the task that's the example. The automation is where the portal and Hilo check-in comes in. Do really nurses have to take that history, or can a patient contribute towards their own care? Because in a team-based care, patient has to be at the center. So we are still working on incorporating patient at the center of the team, but at least we have taken the first step, which is removing physician from the center and making them part of a clinical team and trying to introduce patient to the center.
And actually, the patient component of that was actually going to be my last question to you in terms of, what ways are you incorporating the patient into the care team? Because that's a big component of this team-based care, as you've just said, making sure the patient is part of the decision-making, making sure that they're part of the responsibility for their own health. In what ways is Compass incorporating the patient into that care team?
I think the best example I can give you is all the Hilo features which are available today in the current version, not even V12, self-web enabling patient portal. Like that is tremendous. My staff doesn't have to take consent and patient doesn't have to come to the office to do the consent. They just go on our website, self-web enable. Their family member can do it, and they log into the portal. They refill messages, referral messages, appointments. They can do so much, which they are already doing. Now we have to make them more active participant, which is, apart from administrative tasks, look at your visit summary, information blocking, all the visit summaries, visit notes are in the EHR today. So patients' journey is going to be longer, but I think eCW has all the features. I was amazed to see during the keynote about the price transparency. Like, that's an amazing feature. Wouldn't it be amazing for patients to know before they come what the price is going to be for the care they are receiving?
Yeah, absolutely. Now, you mentioned refills just briefly right there. Can you go into a little bit more detail about why you focus on the refill requests on the patient portal and what impact that's had for you?
So the refill procedures have been amazing return on investment for us, because now patients are going on a helo and requesting refill. That has eliminated a call to the front desk, the telephone encounter going to the refill nurse or an MA, the refill nurse or an MA getting an approval from the physician who's seeing the patients. Sometimes they do their task at 5 p.m., patient calls back within 2 hours, I need my refills, I'm running out. Everything gone, because the task which patient generated goes to the refill nurse or MA directly, and all you need to do is put protocols in place where clinical standards are met and staff can do the refill. So we have a standard refill procedures where physicians are not even involved at this point. As long as patient meets the standard working procedures, patient gets refill done. And patients loves it because they don't have to sit on a 15-minute call time wait before they even talk to a real human being in a call center.
I think that's a great example of this whole concept, because all the things that you've mentioned, redistribution of tasks, including the team, eliminating things that are not necessary. I mean, you cut out all of those steps in between, like you said, the patient call, the wait time, the telephone encounter, and everybody's happier at the end. The providers are happier, the patients are happier, and everything gets done. Dr. Shah, thank you so much for talking with us about this information. We've really appreciated your time.
Thank you for having me.
Now, if you'd like any more information about any of the topics that we discussed here today, you can visit my.eclinicalworks.com, or you can speak with your strategic account manager. Of course, you can also check out our other eClinicalWorks podcast episodes on Apple Podcasts, YouTube, or my.eclinicalworks.com. For the eClinicalWorks podcast, I'm Adam Siladi, and thanks for watching.